Hello everyone, I am Martijn R, a research fellow from the Amsterdam University Medical Centers in the Netherlands, and I am glad to present our results of our study, shortly titled A Computer-Aided Quality Control System for Barrett's Esophagus Endoscopy, which was recently published in Endoscopy. And obviously I would like to start with thanking all co-authors of this paper. Now, endoscopic detection of early Barrett's neoplasia can be challenging. The current state-of-the-art endoscopes visualize nearly all subtle lesions. However, most endoscopists are often unfamiliar with the appearance of early neoplasia, and therefore computer-aided detection systems can potentially aid the endoscopist. In earlier studies, we already developed such a CAD system. However, this was all based on data from expert centers. So our data may have looked something like this, where the endoscopist first adequately cleans the segment and takes enough time to create high quality images and videos. Meanwhile, in clinical practice, image quality can be more diverse. So the first aim of our study was to develop a computer-aided quality system for Barrett's esophagus. We started by collecting a large dataset of retrospective and prospective Barrett's imagery, and often we used videos which inherently contain a wide variety of image quality. So we identified several key factors defining endoscopic image quality. First, objective image quality, which comprises artifacts such as blur or poor illumination. And second, subjective image quality, which we subdivided into the degree of mucosal cleaning and esophageal expansion. We then annotated all data for these parameters with different point scales. For training the quality system, we used roughly 7,500 images from 350 patients. And for performance testing, we used an independent test set of another 50 patients. Over to the results. As you can appreciate, the quality algorithm showed strong agreement with the human annotators. And then we wanted to evaluate this quality algorithm in conjunction with our already existing CAD system. We collected a substantial amount of evaluation data with Barrett's images with and without early Barrett's neoplasia. These images contained a wide variety of image quality again. So it's fairly simple. All images were first analyzed by the quality algorithm, and only images with sufficient quality were subsequently analyzed by our CAD system. And when we go over to the results, we noticed that adding the computer-aided quality system to the detection algorithm substantially increases its performance. And it mainly increases its detection rate with about 8%, while specificity scores remain similar. So this is actually an example case of a neoplastic lesion, and as you can appreciate, the segment is inadequately cleaned and therefore the detection system is not activated. And after proper flushing and cleaning, the segment is now ready for visual inspection, and as you can see, the detection system clearly recognizes the lesion. So in conclusion, computer-aided detection systems are vulnerable to lower image quality. We developed a quality algorithm that can differentiate low from high image quality, and using this system as some sort of filter may reduce the false negative rate of CAD systems.